Hi, everybody. It's Laura Heineman, and I'm going to talk about cardiac physiology on the plain film. So in this day of echocardiography and cardiac MR and cardiac CT, why should we spend time learning about cardiac imaging on the radiograph? Well, remember that chest radiographs are still the most commonly ordered radiologic study. So I think from a patient care standpoint, it's incumbent upon us to be able to recognize abnormalities that are on the radiograph so as to know when to recommend a cardiac workup, including more advanced cardiac imaging. So in this pre-recorded video portion of the lecture, I'm going to talk about the different sorts of pulmonary blood flow patterns that we can see on a radiograph and what each of them means from the standpoint of cardiac physiology. I'll also tell you how to determine whether individual cardiac chambers are enlarged and what to think about when there's global enlargement of the silhouette. Then when we meet in person next week, we'll go over some cases that highlight points from this video, as well as some cases that illustrate important lesions to be able to recognize when you're going through a stack of film. Lesions that may cause focal cardiac chamber enlargement or mediastinal contour abnormalities. So let's start with the different pulmonary blood flow patterns that can be seen on a radiograph. What are you talking about, Heineman? Pulmonary blood flow patterns. What are they, and what does each mean from the standpoint of cardiac imaging? Well, the options for pulmonary blood flow patterns are normal pulmonary blood flow, can have increased flow, decreased flow, pulmonary edema, a centralized blood flow pattern, or a lateralized blood flow pattern, whereby it looks like there's more blood going to one lung than the other. What is normal pulmonary blood flow on a radiograph? Well, normally the main pulmonary artery forms a convexity that is smaller than that of the transverse aorta. The hyla are smooth and symmetric bilaterally, although the left hilar vessel is a little higher than the right. In terms of size, the right descending interlobar artery should measure about 1 to 1.5 centimeters. So that's a ballpark to keep in mind when you're trying to decide whether hilar vessels are too big or too small. And normally, there is more blood flow to dependent lungs, so that on an upright film, the vessels in the lower lungs are bigger than the vessels in the upper lungs. What's increased pulmonary blood flow? What does it look like, and what does it mean? Well, with increased flow, all the vessels are bigger than normal, so that the main pulmonary artery forms a convexity that's a little bit bigger than the transverse aorta. The hyla are big, and the peripheral vessels are big too. And I think those big peripheral vessels make the lungs look busy. What does increased pulmonary blood flow mean? It means there's more blood flow going out to the lungs than normal. And what causes increased pulmonary blood flow? Well, if there's increased circulating blood volume, so that someone who is 9 months pregnant and has doubled their normal blood volume, if they get a chest radiograph, they'll have increased pulmonary blood flow. Someone who has increased cardiac output, before they develop high output failure, they have high cardiac output and can look like increased flow on a radiograph. And from a congenital standpoint, we think about left to right shunts, whereby blood that should be going out the aorta instead is diverted over to the right side of the heart and goes out the pulmonary circulation. What about decreased pulmonary blood flow? What does that look like, and what does that mean? Well, with decreased pulmonary blood flow, all your vessels are smaller than normal. The main pulmonary artery is small, the hyla are small, and the peripheral vessels are small so that the lungs look oligemic. Sometimes the main pulmonary artery is so small that there's a concavity in the region of the main PA rather than a convexity. That's the ankle of the boot in a boot-shaped heart in patients with tetralogy of Fallot. What does decreased pulmonary blood flow mean? It means there isn't enough blood going out to the lungs. So people with decreased circulating blood volume, for example, someone with Addison's disease, can have decreased pulmonary blood flow on a radiograph. Anything that keeps the right ventricle from pumping blood normally into the pulmonary artery, such as in this patient with pericardial tamponade that is causing extrinsic compression on the right ventricle and keeping the right ventricle from pumping, they can have decreased pulmonary blood flow on the plain film. And from a congenital standpoint, we think about a right to left shunt, whereby blood that should be going out the pulmonary circulation is instead diverted over to the left heart and goes out the aorta. Pulmonary edema is another pulmonary blood flow pattern. And when edema is cardiogenic, it implies that there is left heart dysfunction. In very early pulmonary edema, when there's only a slight increase in left atrial pressures that is transmitted back to the pulmonary veins, and so only a mild elevation of pulmonary wedge pressures, that's first manifest on a radiograph by redistribution of pulmonary blood flow. Because this is the pattern that we can see only on an upright film, it's also known as cephalization of flow. So why do we see this redistribution of pulmonary blood flow? Well, when there's early edema, a little bit of fluid leaks out of vessels in the most dependent portions of the lungs. With that little bit of fluid leaking out, there's a little bit of localized hypoxia. And the lungs respond to that local hypoxia by vasoconstriction, so that shunts blood to the antidependent portions of the lungs. So we can only call redistribution on an upright film because on a supine or semi-erect film, the gradient is in the anterior-posterior direction, and we can't tell what's being redistributed anteriorly on a frontal film. So the very first manifestations of pulmonary edema, that redistribution of flow, is something that we can only see on an upright film, and we don't see it very often. If the wedge pressures increase a bit more, the patient develops interstitial pulmonary edema. And if wedge pressures increase more still, they develop alveolar edema. So I want to take a minute to talk about interstitial edema. I think it can be really hard to know when to call interstitial edema on a radiograph. I try to think about edema in terms of anatomy. So before I call interstitial edema, I look for specific findings that let me know that there is fluid in the interstitium. Because when there's interstitial edema, fluid is leaking out of the vessels into all the interstitial spaces. So where are the interstitial spaces? There's a lot of interstitium in the peribronchovascular space. So fluid that's leaking out of vessels and lying in the perivascular interstitium can surrounds the vessels and makes the vessel walls look very indistinct. So it can be really hard to trace out vessels. Really, on a radiograph, you should be able to take a pencil and trace out all the vessels. And if you can't, because the vessel walls are blurry, that might be a sign that there is fluid in the perivascular interstitium. The fluid surrounding the bronchi make the bronchial walls look thickened. So that's what we call peribronchial cuffing. When you see a bronchus on end and it looks like the bronchial wall is thickened, that's potentially because there's fluid surrounding the bronchial wall in the peribronchial interstitium. Remember that there's a lot of peribronchovascular interstitium in the hyla. So when fluid is leaking out of the hilar vessels, it leaks into the peribronchovascular hilar interstitium. It makes the hyla look dense and prominent, and what we call a perihilar haze. Remember that interlobular septa are part of the interstitium and that there are venules in the interlobular septa, so that when fluid is leaking out of venules into the interlobular septa, you get interlobular septal thickening, giving very regularly spaced lines, often parallel the floor. That's what we call curly B lines. And there is interstitium in the subpleural lung, immediately deep to the pleura, so that often in interstitial edema, you'll see the fissures outlined by subpleural fluid. The fluid isn't necessarily in the fissure, it's in the subpleural interstitium immediately deep to the fissure. So I look for all of those, any of those findings before I call interstitial edema. I won't necessarily see all of them. I probably won't see all of them, but those are the radiographic findings I look for before I call interstitial edema. Another pulmonary blood flow pattern that I can see is a centralized blood flow pattern, whereby the main pulmonary artery and the hilar vessels are big, but then the peripheral vessels are normal to small in size, so that the vessels rapidly prune as they go out toward the periphery. This is the pulmonary blood flow pattern that we see in pulmonary hypertension. And again, I think it's you can see that the hilar vessels are big, the main pulmonary artery is big, but if you cover up those central vessels, the lungs themselves look normal. And that's what clues me in that I'm dealing with rapidly pruning vessels in pulmonary hypertension. The WHO has divided pulmonary hypertension into 5 different groups. In essence, the groups are divided into problems going into the lungs, problems in the lungs causing long-standing hypoxia, and then problems going out of the lungs, primarily from left heart dysfunction. So when I see a centralized pulmonary blood flow pattern, big main PA, big hyla, with lungs that look normal or relatively oligemic, I look for clues as to what the cause is. Do I see a big left heart or evidence of prior CABG to suggest that there may be left heart disease? Or do I see evidence of chronic lung disease, such as in this patient with emphysema? I think it can be really hard to distinguish a centralized pulmonary blood flow pattern from increased pulmonary blood flow. Both of them have big main PA, both of them have big hyla. The distinction is whether the peripheral vessels look small or look big. Realistically, I don't worry about making this distinction. I don't think it's my job as a radiologist going through a stack of films to make that specific diagnosis. But I do think that it's my job to recognize that the central vessels are big and that further investigation with an echo or cardiology consult is warranted. And finally, the final pulmonary blood flow pattern we can see on a plain film is a lateralized blood flow pattern, whereby more blood flow is going to one lung than the other. The hilar vessel on one side is bigger than the hilar vessel on the other side. As I mentioned on the onset of this lecture, the hyla should be symmetric. Sure, the left hilar vessel is a little higher than the right, but the vessel sizes really should be about the same. And when they're not, that's abnormal. So on this slide, the left hilar vessel on the case on the left, I think, is much smaller than the hilar vessel on the right. So what can cause this? There are both acquired and congenital causes of lateralized blood flow. The acquired cause that I really don't want to miss is lobar collapse. So the first thing I do when I see that hilar vessels are asymmetric is I look for, number one, signs of volume loss, and number two, an opacity that corresponds to a collapsed lobe, because again, I really don't want to miss lobar collapse. So in this case, in which the left hilar vessel looks small relative to the right, the first thing I do is look for signs of volume loss. And I see some signs of volume loss. Tracheal air column is deviated a little to the left, and the heart itself seems to be shifted to the left. Normally, there's some heart that projects to the right of the spine, but in this case, there isn't. So then I look to see if there is an opacity that would correspond to a collapsed lobe. That means I have to know my patterns of collapse. In this case, I want to look for an opacity that corresponds to a collapsed lobe on the left, since a volume loss seems to be affecting the left lung. And I see such an opacity. There is a homogeneous opacity in the left retrocardiac region that has a very sharply demarcated lateral border. So that is a pattern of left lower lobe collapse. And why does lobar collapse give asymmetry to the hilar vessels? Well, because the artery serving that collapsed lobe is pulled into the atelectasis, and you can't see it. It's only the remaining vessels that you can see in the hyla. In this case, it'll be the left upper lobe artery. The remaining aerated lung, in this case, the left upper lobe, has to hyperexpand to fill the space that's left over from the collapsed lobe. And that fixed number of vessels in the left upper lobe are splayed out in the hyperexpanded lung, making the lung look relatively hyperlucent with small vessels. There are congenital causes of asymmetric pulmonary blood flow, most of which tend to cause blood flow that is lateralized to the left. Congenital hypoplasia of the pulmonary artery almost always affects the right pulmonary artery, so that the right hilar vessel looks small relative to the left. And since with hypoplasia, there is decreased blood flow to the developing lung in utero, and since fetal alveolar development is in part reliant on pulmonary blood flow, a hypoplastic pulmonary artery means that not only will the vessel be small, but the whole lung will be small too. And the end result is asymmetric blood flow, a hilar vessel, and an overall small lung with resultant ipsilateral mediastinal shift. So radiographically, the appearance is very similar to lobar collapse, except, and this is an important exception, there's no opacity that corresponds to a collapsed lobe. So in this particular case, with a hypoplastic pulmonary artery, the right hilar vessel looks small compared to the left, there is mediastinal shift to the right because the whole right lung is small. So it looks a whole lot like there might be a collapsed lobe on the right. And that's the first thing I look for. When I see all those signs of volume loss and this asymmetry in blood flow, I look for a collapsed lobe. And when I do not see an opacity that corresponds to a collapsed lobe, that's when I begin to think about a congenital etiology. Okay, so those are the pulmonary blood flow patterns that we can see on a radiograph. How do you tell if a cardiac chamber is big? Before I go into the specific chambers, I want to emphasize what I consider to be the cardinal rule of cardiac imaging. And that is that the heart responds to volume overload by dilation. So when there is a volume overload lesion like valvular regurgitation or a shunt, the chambers that are involved will get really big. Whereas when there's a pressure overload lesion, such as in valvular stenosis, the chamber hypertrophies, particularly the ventricles, which are muscular. The atria can't hypertrophy very much because they're not muscular, but the ventricles can. So the chamber size of the ventricle involved might get a little bit bigger when there's a pressure overload lesion, but mostly it's hypertrophy of the ventricular wall rather than overall enlargement of the chamber size. So that when I see a really big silhouette with big chambers, I tend to think about volume overload lesions, such as in this case with aortic regurgitation, causing a really big left ventricle. Aortic stenosis, on the other hand, since it's a pressure overload lesion, causes left ventricular hypertrophy, but the overall silhouette isn't that big. What constitutes a big silhouette overall? On a frontal PA film, the overall size of the heart in transverse dimension should be a little less than half the transverse diameter of the thorax. And I never actually measure it, but I do gestalt it with this ratio in mind. How about the individual chambers? How do we know when those are big on the radiograph? Well, the right atrium forms the right heart border, and when it gets big, it protrudes more and more into the right hemithorax. There is a measurement on a PA film from midline spine to right heart border, should measure less than 5.5 centimeters, but I think most people just sort of look to see whether the right heart is protruding more than normal into the right hemithorax. The right ventricle is the most anterior chamber. It's not border forming on the frontal view, but it is border forming on the lateral view, where it is the most anterior chamber in the retrosternal region. And the rule of thumb is that the right ventricle on the lateral view shouldn't go more than 1/3 of the way up the sternum. And if it does, if it goes more than 1/3 of the way up the sternum, that's an indication that it may be enlarged. There are a few signs of left atrial enlargement on a radiograph. On a frontal film, when there is left atrial enlargement, we talk about a double density over the right heart. That double density is the right border of the left atrium. So it's the right wall of the left atrium. The left atrium sits just below the carina. So when it gets big, it can splay out the main stem bronchi. The carinal angle is usually less than 90 degrees. So when it is more than 90 degrees, or essentially doing a split, as it is in this case, then the carina is considered splayed, and that is a sign of left atrial enlargement. Left atrial appendage lies along the left mediastinum, just under the region of the main pulmonary artery. Normally, the left atrial appendage isn't big enough to see on the frontal film, but when it's enlarged, it can cause a convexity along the upper left heart border. So just to reiterate, normally, the left atrial appendage doesn't cause any sort of convexity on the frontal film. But when the left atrial appendage is enlarged, you can see a convexity along the upper left heart border. On the lateral view, the left atrium forms the upper posterior heart border. And when the left atrium gets big, it extends posteriorly and can touch the spine. And remember that the left atrium, because it's subcarinal, when it gets big, the left bronchi can be displaced posteriorly. So normally on the lateral view, the tubular lucencies of the right and left bronchi are in line with each other and with the tracheal air column. But when the left bronchi are posteriorly displaced by a big left atrium, they're no longer in line with the tracheal air column, and they're no longer in line with the right bronchi. And in that case, the tubular lucencies of the right and the left bronchi form an inverted V that look like the legs of somebody walking. So this is called the walking man sign, with the tracheal air column being the torso of the person and the right and left bronchi, the legs. And when you see that inverted V of the bronchi on the lateral view, that's a sign that you may be dealing with left atrial enlargement. Finally, the left ventricle forms the apex of the heart on the frontal film. And when the left ventricle gets big, it tends to droop inferiorly on the frontal film, and it shifts the vector of the heart inferiorly. On the lateral view, the left ventricle forms the posterior inferior portion of the heart. And when the LV gets big, it extends more posteriorly than usual and can touch the spine. Sometimes you can see a vertically oriented SVC superimposed on the heart on the lateral film as the SVC is emptying into the right atrium. And in general, if the left ventricular border is more than 2 centimeters posterior to the shadow of the SVC, it's a sign that the left ventricle is big. Okay, what do I think about when I see global enlargement of the cardiac silhouette on a radiograph? Well, the enlarged silhouette may be due to global cardiomegaly, true enlargement of the cardiac chambers. And in that situation, I think primarily of multivalvular disease, particularly multivalvular insufficiency, so that all chambers are affected by volume overload and become enlarged. So I think about something that will give both tricuspid and mitral regurgitation, leading to enlargement of all 4 chambers. That most often is due to rheumatic heart disease, which is a multivalvular disease. So here is somebody who's got a very big cardiac silhouette. The right atrium and the right ventricle look dilated on both the frontal and the lateral films, but the left atrium and the left ventricle also look dilated on the frontal and the lateral films. This is somebody who has both tricuspid and mitral insufficiency, so insufficiency of both AV valves, leading to dilation of all 4 chambers. And most commonly, when you're dealing with multivalvular disease, it's going to be as a result of rheumatic heart disease. Remember that rheumatic heart disease tends to affect the mitral valve first, but then it often affects the aortic valve and then the tricuspid valve. For whatever reason, it virtually never affects the pulmonic valve. Okay, so I can think about multivalvular disease, particularly rheumatic heart disease, when I see global enlargement of the cardiac silhouette. But I have to keep in mind that the enlarged silhouette may actually be due to a pericardial effusion and not true cardiomegaly. Because remember, what we see on the radiograph is a cardiopericardial silhouette. And both a pericardial effusion and global cardiac chamber enlargement can give a global enlargement of the silhouette. There are some clues that we may be dealing with a pericardial effusion. In a large effusion, the silhouette's often referred to as being globular in configuration and having a, quote, water bottle configuration. If there is a rapid change in size of the silhouette, that would be a clue that we're dealing with a pericardial effusion rather than true cardiomegaly. And then sometimes we can see a sign on the lateral view that we're dealing with a pericardial effusion. This is what's referred to as a sandwich sign or an Oreo cookie sign. It's pretty specific, but it's not very sensitive. So if you see it, you're likely dealing with a pericardial effusion. But on the other hand, you can have a pretty big effusion and not see this sign. So what we see with a Oreo cookie and sandwich sign is we see a lucency that represents epicardial fat. So that's fat that's immediately sort of butt up against the heart, followed by a soft tissue opacity shown here by the asterisks. And that's the pericardial effusion. And then there's another lucency that is the mediastinal fat outside of that. So the inner lucency is epicardial fat. And that's essentially one of the wafers of the Oreo. Pericardial fluid is the cream between the wafer of the epicardial fat and the lucency, the wafer of the mediastinal fat. And I think you can sort of see better here on this cine-AMR, in which fat and fluid are both bright on these true FISP imaging. You can see the epicardial fat that's sitting against the heart. Then you have the pericardial effusion, and then you have the mediastinal fat. So that's the Oreo cookie. Okay, that is going to conclude the pre-recorded portion of the talk. I want to let you know that I have 2 tickets that are going to be available for free for the first person who claims them, for a concert of Sheryl Crow, that's going to benefit the Shade Tree Clinic, which is Vanderbilt's student-run clinic serving the underinsured or uninsured of Nashville. And so if you are interested in 2 general seating tickets on February 15th for a Sheryl Crow concert benefiting the Shade Tree Clinic, give me a holler, and first person who gets them, who claims them, will get them. All right, so I will see you next week, and we'll go over a bunch of cases, again, highlighting points from the talk, as well as some specific lesions to be aware of when going through plain films. See you then.